In the early months of the COVID-19 pandemic, the virus spread fast enough to hit the physical limits of hospital wards. Saving a critically ill patient requires an immense concentration of resources, specifically the specialized staff and the hardware needed for a single ICU bed. We attempted to address the deficit by converting stadiums into triage centers. But when we look at the logistics on this arena floor, it becomes clear that physical space is rarely the primary bottleneck. For a moderate pandemic, models project nearly 1 million patients requiring intensive care, against only 85,000 available adult ICU beds. Even with enough ventilators, the system hits a hard limit. Only 76,000 trained professionals are available to run them. A massive surge in patients transforms rationing from a potential policy into an inescapable physical constraint of the infrastructure. During normal operations, we rely on established rules of fairness. We treat people in the order they arrive, prioritize the sickest in the room, or allocate care based on the ability to pay. This timeline illustrates why first come, first served fails during an outbreak. A patient arriving later finds every resource occupied by earlier cases. Prioritizing the absolute sickest also fails. Devoting a ventilator to one low prognosis patient leaves multiple viable patients waiting. To maintain public trust, this framework explicitly removes personal wealth, fame, or political standing as variables in treatment decisions. Survival during a mass casualty event requires a rigid ethical architecture that prioritizes the health of the population over the intuition of the individual. The primary rule of this framework is the principle of maximizing benefits. This matrix maps the dual goal of the system, saving the highest number of individual lives while also maximizing the years of life those patients are expected to live after they recover.
To reach that goal, priority goes to this middle tier, patients who will likely recover if treated, but will likely die without it. They take precedence over those who will recover on their own, and those who are unlikely to survive even with intensive care. Because saving more lives is the paramount goal, this logic justifies the decision to remove a patient from a life-saving device if it can be given to someone with a significantly better prognosis. The risks taken by medical staff and the general public remain meaningful, only if the system is engineered to produce the highest possible human survival yield. The framework also uses a concept called instrumental value to determine who receives protective gear and early treatments first. This network graph illustrates the logic. Healthcare workers receive priority for equipment and vaccines because their labor ensures the survival of the patients connected to them. If the central node falls, the rest of the network loses its support. However, the priority rules shift depending on whether the medical resource is meant to prevent a disease or cure it. Preventative tools, like vaccines, are allocated first to the most vulnerable, older populations. Curative tools, like ventilators, are prioritized for younger patients who have higher statistical survival rates and fewer coexisting conditions. When two patients have the exact same prognosis, but only one bed remains, equality dictates that a random lottery is the only fair tiebreaker. These rules replace human bias with an objective standard based on utility and systemic equality. To remain consistent, these rules apply to every patient in the system. A person arriving with a heart attack is evaluated under the same scarcity principles as a victim of the pandemic. Without these universal guidelines in place, individual doctors are forced to improvise rationing decisions at the bedside. Forcing a clinician to personally choose who lives and who dies without institutional support inflicts acute, lifelong moral trauma. The systemic solution is to utilize triage officers or ethics committees. Their role is to read the data and apply the guidelines, separating the weight of the rationing decision from the person providing the care. Disaster preparedness is about establishing an ethical consensus before the crisis hits. This framework absorbs the moral burden so that doctors can focus on being doctors.